Good morning. Welcome to the third plenary in the morning session. Dr. Kanishka Silva is no stranger to this audience. He is the president of the Association of Surgical Oncologists and a senior oncological surgeon in Maharagam Cancer Hospital. I'll call upon Kanishka without further delay to deliver his lecture.
Yeah, thank you very much for inviting me to give this talk. And good morning, everybody. And let's look at this interesting topic on clinical decision-making in contemporary surgery using breast cancer cases as a model. If you look at Harrison's internal medicine, according to that, a medical student who takes many hours to take a history examination and come to a coherent presentation, an experienced examiner doing this in fraction of a time seems quite extraordinary. The difference is because the novice actually uses a shotgun approach, expecting to hit a target, whereas the expert has a specific target in mind and he adjusts his testing strategy to it. But even experts in the current day practice can go wrong. That is why we need evidence-based medicine in clinical practice at present. If you take the evidence pyramid, the levels of evidence goes to level 1 to level 5. The level 1 is the top level clinical practical guidelines, and expert evidence generally is regarded as level 5 evidence. The level 1 also subcategorizes into 1, 2A, 2B, and 3. So generally, when you say recommendation in this guideline, it is either category 1 or category 2A recommendations. As a rule of thumb, in contemporary clinical decision making, it's always best to use the level 1 evidence or the clinical guidelines. But situations arise where you need protocol deviation, and such as when there are no facilities to follow this, or patients are unfit, or they are refusing treatment, or there are some specific clinical scenarios outside these guidelines. And that time, the justification of protocol deviation should be done by a senior person, and that goes as level 5 evidence, or they will call it, in my opinion. But it's always good idea to have a MDT discussion and get peer support to it, to your decision and document it in current practice. Otherwise, you can lead to litigations and problems. So let's look at how to handle some of these challenges faced by clinicians using evidence-based medicine in diagnosis, handling patients' anxieties, and customizing treatment to tumor biology. In current era, high-end imaging can detect impalpable lesion, IHC genetic testing can predict occult primary lesions and behavior and responses. Has clinical thinking got any place in this scenario? This brings us to an interesting diagnostic philosophy in clinical practice. William of Ocke, a Franciscan friar, famously said, entity should not be multiplied beyond necessity, meaning simple explanations are more likely to be correct. This is referred to as Occam's razor or law of parsimony. In contrast, Dr. Hickam said patients can have as many diseases as them will please, meaning there can be multiple problems together occurring at the same time. This is referred to as Hickam's dictum. If you look in our own clinical practice, patients with multiple symptoms generally end up in a single diagnosis as Occam's razor. But about 10% cases can have multiple different problems occurring together. When we say main problem and comorbidities, that is Hickham's dictum. These different problems can be linked together due to risk factors, either inherited or acquired, or coincidentally occurring together without any particular reason. So this 10% is the one that can be misdiagnosed and lead into iatrogenic mishap. And this percentage can be much higher in geriatric practice in time to come, and also immunocompromised patients. The current challenge is to recognize these cases in our BC practice. Let's look at our first case. A 68-year-old woman had dyspnea and a fever, and clinical examination found a large pleural effusion on the left side and confirmed by X-ray. It was thought as an infection, lung infection, TB, or a malignant effusion due to lymphoma or a metastatic carcinoma. CTs were done, and CT showed, in addition to the effusion, there were mediastinal nodes. The tumor markers came negative, but a mammogram and ultrasound detected 8 millimeter small left breast cancer and axillary nodes. And a guided core biopsy was done, and it was confirmed as an invasive carcinoma grade 2, Luminal A, good prognostic, low Ki67 tumor. Nodes were negative FNA. So now it looks like a small primary good prognostic breast cancer. Now, as the case was unusual, it was discussed at the MDT meeting. And the MDT decision was, it's very unusual for a good prognostic 68 or to have a pleural effusion and mediastinal nodes. Because of this, the effusion was aspirated, cytology, pleural biopsy, wet biopsy of the nodes were done. All the histology came negative. And TB culture was negative. And this is actual case, I'm telling you. And no obvious reason was found, and it was thought as a lung infection. So this is a Hickham's dictum with two pathologies occurring together, a pneumonia and an incidentally detected carcinoma, whereas he would have given chemotherapy if we didn't go on this line of thinking. So the patient was managed as early cancer with a conservation, breast conservation, aromatase inhibitor, radiotherapy, chemo avoided, and 2 months later the chest CT was normal. So message is in patients with multiple symptoms, outliers should caution the clinician of possibility of a Hickham's dictum. Now let's look at how to handle patients' anxiety in preventive surgery. A 25-year-old woman who had a very strong family history of breast cancer is worried about getting the cancer herself and asking for preventive surgery. Now, in this situation, surgeon along with the genetic specialist need to do actual risk assessment to rationally discuss with the patient. So they have to do a preliminary risk assessment, high-risk cases, models are used to evaluate, and then the patients are categorized into population risk, moderate risk, and high-risk categories. And these are managed, customized on the risk level. The population risk managed like normal people, moderate risk with a mammographic surveillance, and high risk, over 30% risk, qualify for genetic testing, counseling, risk reduction strategies such as lifestyle modification, risk reduction agents, and mastectomy, oophorectomy. Now, do we offer all these to these patients? But you need to discuss this choice, patient's choice, with risk-benefit ratios rather than anxiety because they have it. Now, if you take these patients, there are two categories. One category is BRCA carriers without cancers. The other category is cancer patient who was found to have BRCA gene in them. If you take this second category, bilateral mastectomy clearly will prevent another second cancer with the hassle of undergoing another treatment again. But the question is whether you improve overall survival is questionable. Because if that case is already advanced stage, like stage 4 disease, you're not going to benefit by doing a bilateral mastectomy. So it has to be depend on the stage and biology and the impact of the patient. So if you, on the other hand, if you take a BRCA carrier without cancer, it has clearly been shown overall survival is improved by risk reduction surgeries. But again, it's important to know the patient's age and what their wishes are. So if you take a 25-year-old normal woman, she has an 84% chance of going up to 70 years. That's a normal person. If you get a BRCA1 gene, it will drop to, without intervention, to 53%. That's a drastic drop. But if you offer bilateral mastectomy at 25 years, her chances will improve to 66%. Whereas if you don't offer a mastectomy, do screening from 25 and offer oophorectomy, chances go even much higher to 74%. So oophorectomy is better than mastectomy, actually. So, but on the other hand, if you do a mastectomy at 25, oophorectomy at 40, the chances will go up to 79%. So now it will depend on when you detect and what the patient's wishes are. So that's why you can't just run into ideas like that. So now let's look at people who actually had precancerous lesion and their anxieties. A 56-year-old woman was detected to have a screen-detected microcalcification, but the breast looked normal. And another 60-year-old with a nipple ulcer was confirmed Paget's disease. Now both these patients are panicked and asking for mastectomy. Now in handling situations like this, the surgeons have to get together the radiologists and complete imaging and minimally invasive biopsy prior to open surgery. So microcalcification patient needs a scan, and if a lump is detected, the core biopsy can be done, managed on histology. Otherwise, you can also do an MRI. And the final thing would be microcalcification can be taken out with mammo-guided stereotactic vacuum-assisted core biopsy, VAC biopsy, and if necessary, followed by biolocalization of the area. Paget disease without any other disease in the breast is considered as carcinoma in situ in the nipple. So the message is surgeon's role of excision biopsy is moving towards the interventional radiologies in minimal invasive biopsies. This is a back biopsy done by a radiologist. It's the first case in Sri Lanka, one of our patients. And this is a biolocalization done by us surgeons, helped by the radiologist. So when a lesion is biopsied, the management should the patient's choice should be based on relative risk index rather than anxiety. If the lesion is benign, it has a relative risk index of 1.6, so they can be managed by surveillance. If it is ADH, atypical ductal hyperplasia, tamoxifen can be added. LCIS risk is much higher, 16 bilateral risk, but no local risk. So no point operating them, breast surveillance, tamoxifen. DCIS, the risk is higher than that, 17 with a local risk. For wide local excision, radiotherapy, tamoxifen. Mastectomy rarely needed in multifocal disease. Paget disease without invasive cancer, managed by DCIS. Central quadrant, radiation and tamoxifen. This DCIS and Paget doesn't spread to nodes, so generally no need of sentinel node biopsy unless you are doing a mastectomy. That would prevent a later sentinel node biopsy. Then you may have to do it primarily. Now let's look at how to customize patients' treatment to their tumor biology. A 40-year-old woman presented with a 2 centimeter grade 3 triple negative breast cancer, and she is a nursing officer and worried about aggressive disease, asking if you do a mastectomy axillary clearance, whether chemotherapy can be avoided, whether disease can come back, and what are the other options for triple negative. So these are anxieties that come to patients' mind. This brings us to the question, does aggressive tumor biology require radical surgery? Excision of primary cancer has been statistically clearly shown to improve the survival. Again, the trials on systemic therapy and radiotherapy has shown improvement of both local event-free survival and overall survival. NSABP B06 trial, Milan 1 trial with long-term follow-up has shown overall survival for mastectomy is equal to breast conservation and radiotherapy. So the current recommendation is to get a total tumor resection with negative resection margin rather than going for very radical surgeries. So the extent of breast surgery currently depends on the size of the tumor number, their locations, and the patient's breast volume rather than on tumor biology. So the message is aggressive tumor biology doesn't benefit by more radical surgery, but benefit by appropriate systemic and targeted therapy. So in discussing treatment options, a useful tool is risk calculators. So our patient, the one that I presented earlier, her figures were put to predict online NHS calculator and calculated 15-year predicted benefit, and the surgery showed 74% benefit, CT showed 7% benefit. Additional only 7%. The message is surgery, though is non-specific, works well irrespective of tumor biology. Even in early aggressive disease, still the surgery has a main role. We looked at the trend in our patients in our unit, and 62% of early breast cancer patients are currently undergoing breast conservation. The trend is towards that side now. The next question was patient asked axillary clearance. Does axillary clearance reduce dying of aggressive disease? NSABP B06 trial clearly showed axillary clearance has no survival advantage of sentinel node biopsy, node negative axilla. Currently, because of this, the sentinel node biopsy has become the preferred axillary assessment tool in node negative axilla. So the current purpose of doing axillary surgery is to stage the disease for treatment and prognosis, prevent axillary recurrences with its morbidity. The further development in this area is SU11 trial, where the 1 or 2 nodes positive, still you can avoid axillary clearance if you are giving whole breast RT covering the level 1 axilla. And post-chemo sentinel node biopsy trials have shown sentinel node biopsy is useful to assess node negative axilla. Over 70 patients subset analysis has shown sentinel node biopsy can be even avoided in good prognostic small cancer. So the message is current axilla shows the pathway towards no surgery in breast cancer. This is our first 40 cases in our sentinel node trial. Now we are going over 1,000 cases and we are happy. This is one of our patient's photos. Now next question is, if you are giving chemo, should we give it neoadjuvant or after surgery, adjuvant? A 56-year-old woman presented with locally advanced breast cancer is asking whether we can operate her without chemo. Now, situation like this, MD team, clinical oncologists, pathologists, radiologists need to discuss with the patient prior to surgery. The systemic therapy, as we said, clearly showed event-free survival and overall survival in early breast cancer. The trials have shown, but the trials have not clearly shown whether you give neoadjuvant to adjuvant differs in outcome, ultimate outcome. But the current trials are showing some good results in triple negative and HER positive, so there may be a case. Currently, the neoadjuvant therapy, the main role is to shrink the tumor, so you allow to do a conservation and get RC resection, but also you can use this information to check whether the chemotherapy is working in this patient. So that's an advantage. So let's see what can happen after neoadjuvant chemotherapy. Complete clinical response. A 45-year-old woman with a 3.5 triple negative disease with node positivity underwent neoadjuvant therapy, planning for a conservation later with clip placement in the tumor bed. The patient had complete clinical response, no tumor on imaging. So now patient is asking whether she can avoid surgery. Now here the surgeon, radiologist, pathologist need to discuss with the patient. Now thing is, a percentage of complete clinical response patient actually saw pathological complete response. So now that means no invasive carcinoma, only in situ left behind. And these patients have seen a better event-free survival and overall survival than others, as in this red line in this graph. But the question is, without surgery, how to differentiate between these two categories? MD Anderson and other multicentric trials are checking whether the VAC biopsy can be done. They call it intelligent VAC biopsy in place of doing surgery. So that, but the problem is safety avoiding surgery in pathological complete response is currently unknown, but it may come later. And whether you can avoid radiotherapy also is yet to be seen. So receptor discordance after chemo. 65-year-old patient with a luminal B, ER positive patient, presented with chemotherapy and everything given, surgery done, 2 years later with METs. And these METs showed a different receptor, triple negative. 10 to 30% of recurrences show receptor discordance within the primary tumor and later deposits. Reasons are unknown. Was the disease multiclonal, leaving bad clones behind? Did the metastasis evolve biologically? Or was it a second primary giving rise to these deposits? So answers to such questions are currently unknown and will improve our knowledge on this subject. Then let's look at the future trends in breast cancer treatment. Gene expressions like profiling like oncotype DX in early luminal A cancer, mammaprin, can predict the behavior of the tumor aggressiveness, and if they're aggressive, can give chemo or avoid chemo. Using targeted treatment like based on genetics, epigenetics, Hill signaling pathways have paved way for novel treatment strategies. These have added a new dimension to breast cancer management. The cell signaling pathway and blockers, and especially this magic bullets, that is antibody drug conjugates. Now, HER-positive tumors, trastuzumab can be given. Trastuzumab binds to the cell. So you bind the chemotherapeutic agent to trastuzumab. So it goes and damages only that cell. So these are some of the new advantages, and they cost immensely, and currently out of our situation because of dollar crisis. Summary of monoclonal antibody and targeted therapy: ER-positive tumors like palbociclib, HER-positive tumors, triple-negative tumor, BRCA-positive tumors, PARP inhibitors, all have come into scene. Only question is how to find dollars to buy this stuff. Thus, in conclusion, to provide best benefit to patient, it is very important to clinically evaluate the patient, keeping outliers in mind. Utilize the latest diagnostic investigation, knowing their limitations. Utilize new knowledge of tumor biology in treatment planning. Take patients' requirements and anxieties into account. Formulate MDT plan, combining guidelines with expert evidence. Communicate treatment plan with the patient and telling them the actual benefit to the patient and caregivers. If you follow this pathway, it will help the clinician to be updated with current management strategies, as well as if you do not follow this pathway, you might get into serious complications leading to litigations. So this is the situation in current clinical thinking. And I would like to thank you for patient listening, and all the best for making correct decision making in all your patients. Thank you very much.
Thank you very much, dear sir, for that excellent lecture. And since we are a bit short behind time, we would go for the next event. Thank you very much and wish you all the best.